Hi again. Welcome back. And now we're going to start talking about the alterations of hematologic function. We just went over the norms. And we're going to start with talking about anemia. Anemia is a reduction in the total number of erythrocytes in the circulating blood, or it's a decrease in the quantity or quality of the hemoglobin. Anemia commonly results from three main issues. Number one, an impaired erythrocyte production. So RBC production is impaired somehow from the bone marrow. For example, a vitamin deficiency, or there's just something wrong with the bone marrow, or stem cells. So there's many things, but there's a problem with the red blood cell being produced. Obviously can cause anemia. Secondly is blood loss. Nothing wrong with the bone marrow, nothing wrong with red blood cell production. It's just it's being lost. Common reasons that somebody has blood loss that they don't know about. I mean, obviously trauma and the obvious ones, but two common reasons that people have blood loss leading to anemia are GI bleeds. They may have a slow GI bleed, menstruation, blood loss in an obstetrics situation delivering a baby. So, and of course there's others, but those are two common ones. A third reason that can result in anemia is the red blood cells are being produced, but there's an increased erythrocyte destruction. So like a hemolytic anemia, something that's the blood cells are being produced in the bone marrow. They're being excreted into the bloodstream, but something is causing the blood cells to be destroyed. Hemolytic anemias, anemias that cause the blood cells to not be normal. Chemotherapy, radiation, something that's destroying the red blood cell, or it can be a combination of any of these factors here. Decreases oxygen carrying capacity, which leads to tissue hypoxia. That's a problem. Several types that we're going to talk about here, and they have varying etiology. And just as general manifestations are weakness, fatigue, pallor, syncope, dyspnea, and tachycardia. In this slide, we're going to talk about some different types of anemia, and then we'll talk a little bit more about the symptoms. So as far as the different types of anemia, oops, let me get this right here. So we kind of talked about this in the last chapter, and we talked about lab values. And really what you should do for this chart here, we're talking about color, chromic, sites are cells, macro, normal, micro is size. So these are the size of the cells. Hyper, normal, hypo, color. This is the color. So what you want to put over here and just write in with your pen is MCH. Remember when we get that blood level, the blood test, the MCH as far as the hemoglobin, it's really talking about color. And then this down here, you can put the MCV, which is the size or the volume of the cell. So we need to know the color and the size of the cells, and they get categorized. So just by you can see in the chart is something that is a normal chromic, normocytic. Let's see, color, size. This would be a normal red blood cell. Normal chromic, normocytic. And there are plenty of anemias, by the way, that occur and there isn't a change in the blood cell color or the blood cell type. And then there are some anemias that there are changes in them. Hyperchromic, not very common. Hypochromic, a little bit more common. Normalchromic. So this would be pale. Somebody might have pale, like an iron deficiency anemia. The iron that's not on the heme is going to cause the color to be low. So a low color, a normal color, a high color. Cytic here, macrocytic, big cells. There's macrocytic anemias we're going to talk about. They manifest with these blood cells that look really giant. This is a normal size right here. And then microcytic, there's anemias we're going to talk about that have a micro or teeny weeny little red blood cells we can see under a microscope. or anemias that actually are normocytic as well. So color and size right here. So classifications of anemia, we're going to talk about these coming up. This is just kind of a little bit of an overview. So as far as anemia with a decreased hematocrit and a hemoglobin, we just talked about this, 3 different causes. Either there's a decrease in red cell production, and they will have a decreased reticulocyte count because the red blood cells are just not being produced. So there's low reticulocytes and there's low red blood cells. Acute blood loss, okay, which is just nothing wrong with anything other than the person's bleeding. Or they have okay production, but they have an increased destruction. So something's causing them to be destroyed. And hence we see an increased reticulocyte in the blood in this point, because since they're being destroyed and the blood count is low, the bone marrow is throwing out babies a little too soon. And so that can be an indication that this is part of the problem, because there's reticulocytes that are high. So let's just kind of go back over here. Decreased RBC production, macrocytic, normal chromic. The MCV is high. It's a big cell, so a big volume. Macrocytic, MCV is high. Normal chromic, the MCH is normal. It's in the normal range. Macrocytics, you can probably write this down because this is something we're going to definitely talk about. We'll talk about the macrocytics. Anemias, they have the big red blood cells, macrocytic. The color's fine. It's just the cells are big. The 2 we're going to talk about are vitamin B12 deficiency and a folate deficiency. Those are the 2 main ones that are categorized under macrocytic, and you need to categorize them. And these can be caused by just not a good intake of the B vitamins, pernicious anemia, which doesn't allow the body to absorb vitamin B12, alcoholism, which interferes with the synthesis of the B vitamins. So we'll talk about that coming up. This one right here is a microcytic hypochromic, little cell, little color, pale. A decreased MCV because it's microcytic, so the MCV is going to be low, and a decreased MCH because it's hypochromic. The color is going to be pale, micro. Okay, this is the only one, only micro. There's actually 2 that we're going to talk about. The main one is iron deficiency anemia. And this is the most common anemia. We see this the most commonly. Iron deficiency anemia is caused by either a poor dietary intake, and often, here's the problem right here, chronic blood loss. Also, this is the normocytic, normochromic. So you get their blood work, you get a CBC, you look at their MCV and their MCH, because you're like, this person's got anemia, and MCV and MCH is normal. So if that's the case, then they don't have iron deficiency anemia, and they don't have one of the B vitamins anemia, because they're normocytic, normochromic. And commonly what we see that are normocytic, normochromic are anemia of inflammation, which is very common, especially in the elderly. Or you may hear this called anemia of chronic disease. And it can be caused by infections, cancer, autoimmune, renal disease, common one right here. Cardiac, pulmonary, just any disease can cause it, because it's just like this chronic inflammation that's going on in the body, and it can cause some anemia as far as the red blood cells are not being produced for multiple reasons. But hence, when we look at the red blood cell, there's nothing wrong with them. They look okay because they're not deficient in iron or vitamin Bs. They're not deficient in that. It's just an inflammatory process. That's something. Aplastic anemias we'll talk about, which tend to be kind of like anemias that have problems with the red blood cells, something that's not allowing the red blood cells to be produced, chemicals, drugs, radiation, infection, or sometimes it could just be inherited. So we'll talk a little bit about these 2 as well, and they are normocytic, normochromic. Over here, our third one is the increased destruction. So now this is a destruction of red blood cells. Not a problem here, not a problem in the bone marrow, not a problem with the stem cells, not a problem with the red blood cells. Those are fine, but they get secreted or released in the blood, and then something destroys them. Abnormal red blood cell shapes like sickle cell anemia right here, thalassemia. We'll talk a little bit about thalassemia. It is a microcytic hypochromic, but they have it in this chart over here. So sometimes they just have an abnormal shape and they get destroyed. And the schistocytes, which are also abnormal or fragmented RBCs, they get injured or damaged somehow from hemolysis, and they have these schistocytes, which are seen, and it's an acquired destruction. This is an inherited destruction. It can be autoimmune hemolytic anemia. So we'll talk about these causes. So for as far as this chart, it's important for you right now to know these 3 causes of anemia. And then we're going to talk about all 3 of these. And we're going to talk about these 2 macrocytic normochromic. We're going to talk about the microcytic hypochromic, which is the iron deficiency right here. These normal looking red blood cells, but they have chronic diseases. So we'll talk about the anemia of inflammation or anemia of chronic disease, and an aplastic anemia, that's something like that it is causing an anemia right here. And it interferes with red blood cells being produced. They're not being produced. These people have low hemoglobins, low hematocrits, low red blood cells. Sometimes they have low white blood cells, low platelets, just something that's going to decrease the production. And then we'll also talk about some of these over here, the thalassemia and the sickle cell anemia. Clinical manifestations. So this is a little bit of another kind of a big chart, but let's just kind of focus on what's important here. So as far as whether it's a decrease in erythropoiesis, blood loss, an increase in destruction, what we have is decreased red blood cells, decreased hemoglobin, which gives us an anemic condition. With that comes a decreased oxygen carrying capacity or hypoxemia. With that, if there's low oxygen in the blood, now there is going to be tissue hypoxia because there's not enough blood, or excuse me, oxygenated blood to go into the tissues, which then leads to ischemia, okay, and some other symptoms. So let's take a look at these right here as far as any of the symptoms that occur because of tissue hypoxia, which you know, one, ischemia. They can have claudication of the muscles. They feel tired and weak. Their skin is pale. There's no heme. You know, the heme's low, so the redness, so that blood cell doesn't make their skin pink. It looks white, so their skin and their mucous membranes are pale. They can have an increase of respiratory rate, or most typically their complaint is exertional dyspnea. Oh, gosh, I just got up and I walked across the floor and I'm short of breath. While I was thinking oxygen. Let's take a look at their lungs. Let's get a chest x-ray. And sometimes we guys just like, let's get a blood count, because they can have perfectly fine lungs, and if they don't have any hemoglobin, oxygen carrying capacity, they're going to be short of breath. So respiratory problems. And also, if the brain's not getting oxygenated, they can have any of these symptoms right here: dizziness, fainting, lethargy. Can lead to ischemia and any changes in the major organs. That just kind of goes without saying. So these are important symptoms to know. These are generalized symptoms that come with all the different types of anemia. And then some of the anemias have even specific symptoms that we'll talk about when we talk about the specific anemias. That's important for you to know. But right now, these are the general ones that are just generalized anemic symptoms that are important to know. Then our body compensates, like just loves to compensate. So there's some compensatory mechanisms. Number one is the cardiovasculature, which is compensates. And the main symptom, the main compensatory mechanism right now that you see right off the bat with these as the anemia progresses is this right here. Circle that. Increased heart rate is a compensatory mechanism. Just because somebody has anemia, it's not going to cause them to have an increased heart rate, but it's certainly going to, if it progresses, the body says, hey, let me help out and let me increase this heart rate. And that way I can get more oxygenated blood to travel around to your lungs, to your brain. Okay, so compensatory mechanism, cardiovascular, they have an increased heart rate. Oxygen, increased oxygen demand for work of the heart. Okay, so if somebody has anemia and their oxygen demand increases, it can cause somebody to have some angina, right? So they're not getting enough oxygen to their heart muscle. Increased erythropoietin is going to occur. We talked about the negative feedback system that stimulates the bone marrow and will increase red blood cell production, and hopefully then that's the course that it will take, and the person will be better. So that's a compensatory mechanism as well. Capillary dilation, blood pressure, can start going down. Renal compensation, we'll talk about this. We've already actually talked about it as far as the renin and aldosterone response. And that is because, not necessarily because of anemia, but because of low blood volume. So maybe some capillary dilation and can cause low blood volume, and hence that's when we get the renin aldosterone cascade started. Yeah, I think that's good for that right now. Those are the main things I want you to know. So anemia is a blood loss, or acute blood loss. Post-hemorrhagic anemia is a normocytic, normochromic, right? Nothing's wrong with the blood cells. They're just bleeding, caused by acute blood loss. Acute blood loss is mainly a loss of intravascular volume, and its effect depends on the rate, obviously. The faster they hemorrhage, the more symptoms they're going to have, the quicker. If the blood loss is rapid, it can lead to a cardiovascular collapse, to shock, to death. A major cause of acute blood loss is trauma replaced with fluids. Okay, so fluids is the replacement as far as blood loss that can lead to any type of a cardiovascular collapse, decreased blood pressure. First line of treatment is replaced with fluids, and consider a blood transfusion. Basic guidelines in regard to when is a blood transfusion ordered. It is, that should say less than 7 milligrams, not greater than. So change that. Sorry about that. So consider transfusing if the patient has a hemoglobin less 7 or less. I really screwed this up. This should be less than or equal to 7. Okay. So if a patient is asymptomatic and they have a hemoglobin of 7, you got to use some clinical judgment there. If they're symptomatic, then we definitely want to transfuse them. But usually, I'll tell you in practice, when the hemoglobin hits 7, that's the trigger to go ahead and start transfusing with some red blood cells. 1 unit of red blood cells will increase the hemoglobin 1 milligram. So if you give somebody has a hemoglobin of 7 and you give them 1 unit of RBCs and you check a CBC afterwards, their hemoglobin should be 8. If you give them 2 units of red blood cells, their hemoglobin should be 9. And generally that's what we give. 2 units go from a 7 to a 9. If somebody has acute coronary syndrome, we have to consider transfusing a little bit higher. Maybe 8, 9, even 10, depending on how fragile somebody is, okay? We're talking about massive blood transfusions for patients in traumas and stuff. There's different criteria that is used for that, but in general, those are the guidelines for transfusing. The American College of Surgeons uses this classification to divide hemorrhagic shock into 4 classes. Class 1, in regard to blood loss, class 2, 3, and 4. Up to about 15% of the body's blood loss, which is up to about 750 milliliters blood volume loss. Patient is generally asymptomatic and vital signs generally are normal. Okay, these are kind of the criteria here. Capillary refill still good, respiratory rate still good, they still got urine output here, blood pressure is normal. Pulse can be greater than 100, but remember this is the first compensatory mechanism when the body has an anemia due to blood loss or whatever the reason is. So heart rate goes up. Other than that, everything looks pretty good. It says slightly anxious here. Then class 2, obviously more, it says 30% loss, which is anywhere from 15 to 30%, which is 750 to 1500 milliliters. Heart rate goes up, pulse pressure starts dropping. Even blood pressure hasn't really changed yet. Capillary refill, kind of borderline. Respiratory rate starting to go up, urine output starting to go down, and we can start seeing some mild anxiety here. And then we start getting into the third class, which is 30 to 40% of the body's blood loss. They're losing 30 to 40% of their blood loss. Now you can see a change in all of the symptoms right here. They're anxious, they're confused, their heart rate is up, their blood pressure is down, pulse pressure now, there's a big range. Capillary refill is sluggish, they're huffing and puffing, and we don't see much urine output. This would be pretty consistent of this much volume. and class 4, which is greater than 40% of their total volume, which is 2 liters, a little less than 0.5% of what their cardiac output is, you see these big symptoms: fast heart rate, blood pressure is really plummeting, pulse pressure is wider, capillary refills so sluggish, they're really huffing and puffing, no urine output, confused, lethargic, losing their level of consciousness. So you don't need to memorize this. This is just something that's kind of helpful, because you just don't want to think all blood loss is created equally. It's really not. And when you start seeing these symptoms here, you can recognize that that's a significant amount of blood loss that these patients are losing. Okay, when we come back, we will continue with the different types of anemia. Thank you.